Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Hello, I'm Pam Arlotto, your host of the Eye of the Needle podcast. Many healthcare organizations say they want to innovate, but few are willing to reimagine care from the inside out. In this episode, I'm joined by Dr. Karl Kochendorfer, Chief Health Information Officer at the University of Illinois. He is doing just that by launching a clinic designed around innovation. Dr. Kochendorfer's journey from clinician to informatics exemplifies the evolution of Health Informatics 2.0 to 3.0 and beyond, where systems of engagement and innovation drive new care models, better outcomes, and smarter use of data. Today, we're going to talk about how his team is integrating technology, workflows, and clinician input to test, learn, and scale what works, and why the CHIO is uniquely positioned to lead this change. He will share his vision for his initiative, launching an innovation clinic embedded within an academic health system. We'll explore how his background in family medicine and health informatics uniquely positions him to lead this transformation. From care redesign and digital experimentation to data-driven decision-making and cultural change. He will walk us through the challenges and opportunities of building a learning health system from the inside out. We'll also get into what success looks like for his patients, for his health system, and for the future of primary care, or how others can follow suit. Whether you're a CHIO, CMIO, an innovator inside a health system, or just curious about what real clinical change looks like and how it takes root, this episode will offer a roadmap, a reflection, and a healthy dose of inspiration. So, Karl, I've known you for some time, and I appreciate you joining me today. Can you tell our audience a little bit about your background and what led you from clinical medicine and health informatics into a leadership role?
Sure. And I actually, for me, it was a little different than many clinicians. Many clinicians get into medicine and then start working in quality or other areas, and then kind of fall into clinical informatics and leadership. For me, it was kind of the reverse. I kind of grew up learning computers. My dad taught me when I was 7 how to program, and so then in high school, my brother came home from getting an engineering degree and said there's going to be a future in computers and medicine. And for me, that was kind of the light bulb moment that I decided that, this is what I wanted to do. I had a lot of friends that were going into medical school, and this was a perfect opportunity for me to kind of combine my interest in technology and computers and programming, but also kind of lean into the love for sciences and still be able to follow the path that some of my friends were following at the time.
You had a very smart brother. That's fantastic. So when we first met, we met at the AMDUS crash course, and you and I've had a number of conversations over the years, and you reached out about the framework that we highlighted in the very first episode of The Eye of the Needle. And that framework, we were able to kind of break it down in terms of the implications for the CHIO and CMIO role. We've recently just added a 4.0 that talks about the whole ecosystem of care and innovation that we're building. Where do you think your organization is, and what are your thoughts about the importance or value of health informatics as we move from 2.0 to 3.0 and 4.0?
Yeah, no, absolutely. And for your listeners, I think you've got your first podcast kind of talks about your framework. And I just thought it was such a great framework of trying to understand, this evolution, this journey to high value, healthcare. And personally, I don't know any health system that has fully achieved and realized the benefits of 3.0, much less 4.0. I feel like we're all at different stages of change and innovation. even with our own health system. For example, we dabbled with remote patient monitoring. And now I think they more appropriately name it remote physiologic monitoring, which I think you have as 2.0 on your framework. When COVID hit, we had a home visit program. And so we were monitoring some of the patients that, were homebound and couldn't get out of their house. And so we, partnered with a third party and started to track some of their physiologic measures. But then, there's a cost to it, a lot of time, and it kind of fizzled out. And COVID obviously settled down and we moved on. We're
Right.
still trying to do some chronic condition management at the population level, still need to do a lot more. We do some, and partly that's Chicago as a market still has a lot of fee for service, which does not incentivize population health. So I'm hoping in a small way that our new innovation clinic within our Department of Family Medicine can kind of help drive forward on that journey.
Well, some of our listeners may not be familiar with what a chief health information officer does. Can you talk about what that role entails and how it's evolved over time at your organization?
Yeah, no, absolutely. I've had the role for 12 years now. I've modeled the role after the three pillars of academia. So effective healthcare delivery, value-based education, informatics research, and innovation. Those three kind of tripartite mission aspect that most academic medical centers have. And my role started with some classic activities like helping us secure $38 million in meaningful use dollars, founding a guidelines and protocol oversight committee, which we call GPOC, the ICD-10 transition, EHR governance, data governance. But they also asked me on the first day that I started the job to take on some less classic roles for informatics, like our clinical documentation improvement or CDI department. So it had previously failed, partly because they didn't have any clinicians helping with it. So they said, why don't you do it? I said, well, is that building physician templates in the EHR? They said, oh yeah, that's what it is. I was like, well, I've done that. I can do that. Little did I know that it's completely different than that.
Right.
But we were able to demonstrate a $12 million increase in revenue per year by our case mix index increase, but also helping to create our clinical informatics fellowship training program, one of the first 4 in the country. And that's one of the roles that I cherish the most, training, mentoring, guiding the next generation of board certified clinical informaticists. One of the mantras that one of my colleagues and associate CHIOs, Dr. Bruce Levy, instilled in me at the time was, we're not just training the next generation of CMIOs, but the future leaders of healthcare. So in just 10 years, some of our trainees have gone on to be CMIOs for sure, which is, part of the hope and goal of many CI fellows.
Right.
So chief quality officers, chief innovation officers, department heads. So we've had 20 graduates so far, and they've, over those 10 years, have taken on some pretty prestigious roles throughout the country. So it's been really exciting to see that. And now it's actually a very interesting time for me personally in my role at UI Health. I've met with several health system leaders over the past 6 months, and we feel like it may be time to reimagine the CHIO role. As our prior trainees have become very capable CMIO and Dr. David Chestick, working on all things operational. One of our trainees, Dr. Sagar Harwani, is now our Chief Quality Officer. One of my associate CHIOs has also become the Chief Research Informatics Officer, Dr. Andy Boyd. One of my other associate CHIOs has become the president of, or is going to be the president of our medical staff in another year. And
Wow.
there's lots of many other folks that have helped us succeed. So we're kind of thinking about and ready to maybe create some type of chief digital or chief AI or chief innovation role. And we'll see if I get the job.
Well, what you just explained so eloquently is that the health informatics role, there's so much potential for it to touch on so many parts of this digital organization that we're building. So many organizations still kind of think of it as optimizing the EHR, but you just gave a pathway for so many different leadership roles, and that's fascinating. So, if innovation is part of that future, and I know you've shared with me your desire to build an innovation clinic, can you help define what is an innovation clinic and a little bit about what you hope it will be ultimately?
Yeah, our vision is to, transform the care we deliver to our patients at UI Health and beyond. we're beginning in primary care because I'm a primary care doc with hopes and plans that I can expand it to other specialties. And, our mission is to have a place to pilot new technologies, new models of care delivery, increase patient engagement, improve population health outcomes. From my perspective and our organization's perspective, every person deserves access to the best care available. And we, hope to bring this to our entire patient population at UI Health. I'm kind of envisioning concierge level care to everyone, despite their ability to pay, especially those on Medicaid, since that's our largest payer, since we're the state healthcare delivery institution, without that hefty price tag.
Will this clinic have a North Star as its mission? And who are those patients? You said all patients, but are there any unique characteristics of the patients you aim to serve with the clinic?
Yeah, part of our eye care values is being inclusive and making sure that we're trying to help reduce or eliminate health disparities. So, we care for a lot of vulnerable patients, ones that traditionally, haven't sought care, don't get care, don't have the resources to get care. And for us, that's an important part of it. And so for many, that's those that might be on Medicaid or don't have insurance. We have a federally qualified health system at our Mile Square location that whether patients can pay or not, that they can see and care for them. So that's our North Star. That's, what making sure that if we can care for them like the patients on the North Shore of Chicago or in the Gold Coast, then we know we're doing the right thing.
Did you have a specific moment in time where you had this aha or insight that really catalyzed this concept?
As I mentioned before, I did have an aha moment when I decided to kind of combine my career in computers and medicine after that conversation with my brother John when I was in high school. But this one feels like it's been a long journey. When I decided to come back to Chicago in 2012, it was definitely after a visit to the Merchandise Mart in Chicago to check. And during the interview, the head of our tech transfer office, Nancy Sullivan, said, she was interviewing me because I said, hey, I try to work in technology. I want to know if we're creating new IP, how do we commercialize that? And she said, oh, you got to come with me to check out 1871. So that was the year of the big Chicago fire. And so that's the name of the incubator for the tech startups. It had just opened on the 12th floor of the Merchandise Mart. It was 50,000 square feet of space. We went there, we didn't get there until 6 p.m. at night. And I was just blown away. There were 50 to 60 programmers and dreamers all hanging out, brainstorming about the next Groupon, YouTube, or PayPal, all tech companies that, had Illinois ties. But then the one of the people that founded 1871, Steve Collins, he birthed a smaller incubator on space. It was only 25,000 square feet called Matter. And it's a health tech incubator in the Merchandise Mart just down the hallway from the 1871 that was founded in February of 2015. So I became a mentor to those startups. I had monthly office hours. I probably met with hundreds of companies over the past decade, helping give them advice on how to break into the difficult to tap healthcare space, which is pretty conservative and doesn't like to necessarily bet on a startup that doesn't have any traction or sales. But one of the other mentors, who's also an ED physician and a startup founder herself, Dr. Carrie Mendoza, her and I had seen that the AMA, the American Medical Association, had donated some space to Matter to create the interaction studio or clinic. It was a mocked up fake clinic within the incubator. So we kept thinking, this is nice that there's a fake sink and a fake, exam table. But what if, being an ED doc and me being a family doc, could we, come up with something a little bit more, realistic? Could we have like an urgent care clinic or something that we could have real patients coming to, and then the startup companies could actually be, those that might make sense could actually be testing out their software in that space. And so we approached the CEO of Matter at the time, still Steve Collins, and asked him if he could help us. And he thought it was a great idea initially, but then it was down to reality of the plumbing stack in the Merchandise Mart, which is a very old, big building, didn't go by that interaction studio. So the walls didn't support a real clinic. And so they're like, well, you need functioning water if you want to have
Or a real
clinic.
sink.
A real sink, right? Exactly. So he posed the question to me like, well, why wouldn't one of the health systems in Chicago do this? Why does it have to be, sure, Mater could be a part of it, but why wouldn't U of I or Northwestern or University of Chicago, build something like this on their own? And I was like, well, I agree. So then I approached some of our leaders within the health system. And there was one chief medical officer at our federally qualified health center, Dr. Cameron or Cami Matthews. I approached her. I said, hey, what about this idea to, Miles Square? We had a brand new building that went up, had some open space that wasn't used yet. So she was loving it. And then she left for a prestigious role in the federal government within a couple months of that. So, you find champions, you find stakeholders, but then sometimes you just got to start over.
Right.
So I serve on the executive committee of our Discovery Partners Institute. So that was another initiative that was trying to build and promote innovation across all of our university sites in Urbana, Springfield, and Chicago. And so I started asking them. They're building a new building in a new space on the south side of Chicago. I was like, oh, this is perfect. So I, was serving on the committees, suggesting these kind of ideas. And after about 5 years of doing that, that space fell through. And so just recently in the last year, they've said, you know what, we're not going to be building the space. We're going to do it part of the Quantum Park that's getting built in the further south side of Chicago at an old U.S. Steel site. And so again, had to start over. The pandemic in the middle of there didn't help. So finally, I'm like, okay, what do I have control over? What do I
Right.
more,
Right.
and so my department was just always a big believer in me and in some of the ideas that I had. And I said, what if we just take the clinic I'm at? And what if we just make it and carve out a small portion of it and say, this is the innovation clinic. We don't maybe have to have a brand new, shiny, spanking building to do this. And
Right.
they believed in it. So in the last year, I got our clinic director, our clinic director is Rita Sma. Our new medical director is Dr. Matt Whithouse. So our department head is Dr. Mas Jimbo. They just love it. So they're very supportive and like, hey, let's go with this. Help me pitch it to the dean and other people. And we're like, look, I need a project coordinator to kind of help me kick this off. So in the last year, we hired a strategic project coordinator, Tyler De La Cruz. He's just been amazing, helping me manage all these projects. I mean, I can't even explain how many we've kind of kicked off and helped with. And then just this month, we finally hired a nurse dedicated to this clinic, Jenny Hernandez. So it's been a journey. It's been 10 years. So if I'm not anything, at least I'm persistent.
Well, that's what it takes, though. I mean, this is a different model, and it takes that persistence to kind of drive it through. As you said, there were a lot of projects, and you've gotten a project coordinator. Or are there any specific problems or opportunities that you're wanting to solve or address early on with this innovation clinic?
Yeah, I mean, I feel like I felt for the Matter startups. I had my own startup. I finally dissolved it literally after like 23 years a couple years ago because it is just so hard to make it work. We sold off or spun off some pieces of it, but it is hard. This is why they say, only 1 out of 10 companies, may make it. And these companies need someone to see their dream and give them a break. So over the years, I've identified a handful of the technologies that I've talked to, and we've explored some more. There's one pilot program that aligns with our department and university mission, helping serve those that may have worse health out disparities, including our LGBTQ plus patients. So we actually partner with a company called Inclusive Plus. Interested clinicians can learn more about how to come alongside that unique population. And so it's trying to help these startups pilot their technologies. But for us, there's other just basic stuff that the chronic disease management, the remote physiologic monitoring, those things exist and there's revenue potentially behind those things. So I want to prove to the organization and to us and to everyone that, you can do that and do that well and have it hopefully, improve outcomes and patient satisfaction. And then we can help these companies, help them learn and grow or fail faster. And so from an academic side, it's not all bad to produce scholarly output, presentations, posters, papers. There might be some new IP creation, but basically help take care of our patients better and drive innovation.
Well, and the whole purpose of this podcast and the reason we called it Eye of the Needle is there's so many problems and challenges in the industry. And on the other side, there are all these new companies and disruptors that have all these new concepts and new approaches, but getting them together sometimes is very, very difficult. And it's so great to have somebody with your leadership background, your understanding, willing to facilitate that and orchestrate that, because that's the only way we're going to drive that kind of change. Do you believe being within an academic medical center and having someone like you who's the CHIO, does that uniquely position you to lead something like this?
I think so. I think so. Again, especially academia has, kind of the three-part mission, and a lot of non-academic centers, obviously good quality patient care is what they, plan to deliver. But by having the education component, having the research component, we have access to grant writing, easier for us to go after grant funds, seed funds, bright colleagues, bright learners. And my role is not being only just a family physician and healthcare leader, but also to innovate, to research, be a researcher, be an educator, and that I very few places value that and allow somebody to try and incorporate all aspects of that in their career.
That's fair. So is the clinic structured differently from a traditional primary care or specialty clinic? Is there something unique since you've layered in this innovation component?
Yeah. One, I think small, like, I've tried to affect change in our entire clinic, and we do, and we have, and we continue to do that. But there's times when it just takes a lot of time and effort to get and work through things when you're trying to train 10 MAs and 30 doctors and 6 nurses. So I said, look, let's start small. Let's get a, SWAT team. So it's a small team. It's 2 doctors, me and Dr. Brandon Harris, who happens to be another board certified family physician and clinical informaticist, and our associate CMIO for outpatient care, who happens to be my primary care doctor. We've hired on the one new nurse, Jenny, one main MA, Abby, and a backup, Mary Fuller. We keep our other leaders in the clinic, the clinic director, the medical directors, the department head, and the enterprise engaged and informed on our progress and efforts. We vet new technologies and attempt implementation. Some succeed, some fail, and that's okay. That's what we expect, and that's what we hope. But then those that succeed, how can we then get them throughout the rest of the clinic, and then how can we get them through the rest of the enterprise?
Right. So can you help us understand a little bit more about the types of innovations that you're either doing or you see doing, whether it's a digital tool or a workflow redesign or even a new care delivery model? Do you have any that you're prioritizing?
Yeah. I think we talk about this when we teach at the AMDIS crash course a lot, that you want to align to your enterprise.
Mm-hmm.
If you are not, if you're going off on your own and doing your own thing, that to me is a recipe for disaster, and people not wanting to support and buy into what you're doing. So for us, our strategic initiatives are be a zero harm organization, high quality, optimize the patient journey or the patient experience, be the best place to work so that the clinicians are feeling like they're supported and valued. But we want to grow. So can we serve more patients? And can we fund our future? No margin, no mission. And so, we need to be able to have our initiatives focus on those things. Right now, we went from some of our best financial times ever as an organization to some of our worst right now. And, with funding for research at risk, with there's just so many unknowns, tariffs and potential costs of supplies going up. We had a nurse strike last year, and that took some time and resources away, but we've recovered from that, and now I think we've got an even stronger nursing group, and we're going for magnet status. So I think aligning with the organization's priorities, doing things that will make an impact and serve our patients better. So as long as we're prioritizing those things and aligning with the organization, then I think we can be very successful. And so far, in our limited launch, we have been.
That's great. So with these initiatives, are there any specific health outcomes? I mean, you mentioned margin a bit ago, but what about
Yeah.
clinical outcomes
Yeah.
that you're
Yeah.
targeting early
Yeah.
on?
No, that's great. So we do get some incentives from our Blue Cross Blue Shield contract. And so, we know we need to do better at our population health management, chronic disease management. So to me, back to the basics. So we've got 7 pop health outcomes: blood pressure and A1C control, eye and kidney screenings for our diabetics, and then breast, cervical, and colon cancer screening. So these are some, pretty common things, and we do okay in them, but I want us to do great in them. And
Yes.
how do we achieve excellence in all of those areas? And as you said, it's not just stopping there. We want to have the highest Press Ganey patient satisfaction scores. So we've actually taken our Press Ganey scores, we've put it into our Epic instance, which not many organizations have done. And now we can actually slice and dice the data in a unique ways and by population that you can't do with just the Press Ganey scores themselves. So I'm trying to build a dashboard where I can weekly look at our scores and
Right.
see what are our patients telling us and how do we make change. How, as you said, fund our future. How can we have the highest RVUs? There is a money left on the table when you don't, we've been for 4 years, I've been collecting patients' blood pressures for those willing to do it. We hadn't billed for it because we wanted to make sure, we had to go through all how do we be compliant with this? How do we get the patient consent? How do we, there's lots of little pieces that you got to put together. It's one thing to do it, but it's another thing to do it compliantly and make sure that the patients are okay with it. We've been piloting it, but now we're ready to bill for it. So let's make sure we're doing that. And how do we have the happiest clinicians at the lowest cost? So to me, it gets back to the quintuple aim, and part of my personal mission statement is, develop, deploy, and evaluate health IT solutions to help doctors and nurses take better care of their patients, with better outcomes, better experience for the patients and the clinicians at lower cost, and done as equitably as possible.
Well, we've kind of been a risk averse industry for a long time and haven't all had a culture of innovation. How are you balancing real world care delivery needs with this experimentation that you do as an innovator? Are you doing pilots, or are you having full on, once we implement it, we're going to, scale it within our clinic? I mean, how does that work in terms of this new kind of experimentation and innovative culture that you're building?
Yeah, it's hard, and it's a mix of pilots, and if they're successful in a functioning clinic. So, some people always say you're calling it an innovation clinic. Well, then will patients even show up to that? Like, or they feel like they're being experimented on? Or it's like, no, these are the same patients I've always had. It's, because I have that relationship with them to say, hey, look, I am piloting this. Are you, getting their consent to say, is that okay if we do this? And almost never do they not want to participate in it because we have the relationship to be able to do that. But I've got a great team of folks around me, and so that just helps. And so as we, have some success, trying to figure out, okay, now we're doing this with the same type of MA that's working throughout the rest of the clinic, the same type of nurse working with the rest of the clinic. So how can we make sure that they're comfortable buying into these things? Because as you add new things to somebody's list of things to do, they're resistant and they're resistant to change. But again, if we can get that identity of, look, we want to be the best clinic that's out there, and part of that is to be able to innovate and having that identity that we're trying to develop and nurture. To me, that's a key piece of this, and getting a good motivated team to kind of get behind this as well is instrumental.
Well, I'm sure with your persistence and the years of bringing this into reality, you've learned a lot about cultural change. And what are the lessons that you have learned about the change that's required to support innovation in a clinical setting?
Yeah, good question. Again, it's hard. I mean, it's hard. But I would turn to our good friend, Dr. Howard Landa. When we gave one of our crash course sessions, I was talking about how John Cotter's got a good book on change and talks about the burning platform, and Howard always says, you know what, the 8 steps in Cotter are great, but I love simple. And so he always recommended the book by Chip and Dan Heath called Switch, and
Yes.
where you've got a writer. That's the kind of the brain thinking piece. You got the big elephant, the emotional piece, and then you got a pathway. And how can you tap into the use data to kind of get into somebody's understanding of, how change may be important, but the bigger piece is their emotions. And
Mm,
how do you find an identity, an emotion that can actually help to get people to want to change? And it's not just always a burning platform that hey, we're losing $40 million. Everyone's got to, freak out, run around and jump off a burning platform into the
right.
to want to change. That may not be the best way to get long-standing change. That might be a good quick fix for something, but if you really want to get long-standing change, making the path easy and tapping into the emotions and relationships and leveraging relationships with people, that's what can create long-lasting change.
That makes so much sense. But I bet you've had some surprises, some barriers that you didn't expect, or unexpected champions along the way. Any of those?
Oh yeah. Oh yeah. Yeah, as I said, I mentioned, had some champions, but then they might move on to another position. So that's always a little bit heartbreaking, or we get excited
Mm,
about a potential location and then, it ends up falling through. Um, but just, going where you are accepted and where people are welcoming you in. So again, I kept looking for jumping right into the enterprise and doing this for the enterprise, and that's where we're going to start. And it was hard, and would get some, last summer when I presented this to the ambulatory leadership across all ambulatory, and I mentioned how, we think we can generate revenue from this, especially with remote physiologic monitoring and doing some better billing and documentation. And they said, well, if you're targeting some chronic disease areas, great, we want you to do that. So maybe you're not ready to call it an innovation clinic yet. Maybe call it a chronic disease management program. And I'm like, fine, that's fine. I'll call it whatever you want for now.
whatever
Whatever
whatever it
it,
takes.
whatever it takes. But for our department, that that everyone in our department has bought into this and believed in it, and the leadership. And so that's where we started saying, hey, this is the Department of Family Medicine Innovation Clinic, and once we prove out that we can generate the revenue, that we're doing more than chronic disease, then it makes it easy to go back to the enterprise to be like, okay, see, we've made some progress, we've said what we were going to do, and now we're ready to expand this to the enterprise.
So it does sound like you do have plans once it's successful, or you can demonstrate success, to scale it beyond your clinic to the enterprise. What about beyond that? Do you want to take it elsewhere, like to other organizations?
Yeah, I would love to. I mean, I think at one point you were um, asking me, in 5 years, where do you see this? And my goal, not only be a premier primary care site that, could be providing concierge level care to our patients without the price, but also, doing that in other primary care sites, but then other specialties. I think that a lot of the lessons that we're going to hopefully learn, we can expand to other specialties. But then I haven't seen this in the country too often. And so I'm looking for places. So if anyone has one, please let me know. I'd love to do a site visit. But then could we be that site visit? Could we
Yes.
be that destination clinic that we could show people how we did it, and they could learn from it? And that would be my hope, would be a destination site for others to come to and see how we were able to achieve the outcomes that we've achieved.
Well, you mentioned working with Matter and the other innovation and hubs and incubators in Chicago, but there are a number around the country in healthcare. So my gut is your model will be very interesting to those guys, as well as they look for places to partner and individuals like you to kind of facilitate that intersection. So do you see this model or this concept influencing the role of health informatics?
I do, and I think it takes a page from your framework, that kind
Mhm.
of that 4.0. I think we can move into that. You know, some places are having chief digital officers, digital transformation officers, or just chief transformation officers, or chief strategic officers, somebody that can kind of help, that understands the data, understands how it gets applied for clinicians, beyond just optimizing the EHR, and can really help with transforming an organization to take them to the next level. Any good healthcare leader these days has to understand data, has to understand how to get data, how to understand the data, how to apply the data. And so to me, the foundation that we've learned in informatics is really instrumental for true organizational transformation, true leadership, and as you said at the beginning, trying to build a learning health system. And I think that's
Mhm.
that's our goal.
Mhm. Mhm. Well, and you have for a number of years talked about the value of health informatics in the crash course at AMDUS. And, and we've talked about organizations still are focused on optimizing the EHR. And I always say they're kind of stuck at 2.0 if that's all they're doing with health informatics. But what you're really describing is impact in a much bigger way. And I assume that's part of that vision and goal for you.
It is. It is. And it's great to have that next generation of leaders and learners that I learn just as much from them as they might possibly even and learn from me. So it's just great to kind of be in that environment, and I just love that aspect of it.
So if another CHIO or CMIO comes to you and they are like, I want to do the same thing, what's the first advice you would give them?
Well, I hope it's not too cliche. I mean, I think finding where you're passionate. So for me, it was, took a while. I thought I was going to be a radiologist. I actually got to work briefly with the guy that created the MRI, Dr. Paul Lauterbur. He ended up winning the Nobel Prize, and he had me one summer trying to extract gray and white matter from brain images. And it was an okay experience because actually my programming skills were not the best. And ended up realizing that I wasn't going to be a radiologist, that a family doc was really the path I had to go. So to me, telling people, find the path that you feel like you are the most gifted in. For me, leadership, administration, and are some of my are some of my giftings, and so find where you're, have those skills, and then how you can apply to find your calling. And for me, it was being a family doc and doing informatics. And I just love the broad spectrum of that family physicians get to bring to the table, and that was been really instrumental for me in my career. So find that area that works best for you, and find where you can uniquely serve.
Right. That's really great. So I like to close with some rapid fire questions and kind of whatever first comes to mind. So what's the one technology or trend you're most excited about right now?
Yeah, I'm gonna be cliche like everyone else. So AI has got a lot of
Of
promise.
course.
But we have a new AI Health for All Center, and we've hired some new postdocs. I sit on the board, and I think there's just a lot of excitement and promise of what we can do. And we've been piloting the augmented response technology to reply to patient messages, and that's been really helpful in reducing the cognitive burden and load that it takes to kind of respond to patient messages, as many as we get. Also doing the ambient AI dictation,
Mm.
and listening, and I've just loved it. And at first I was like, well, it doesn't do orders yet. It doesn't do problem-oriented charting. Oh, this isn't going to be that great. And then I've used it for every patient since. And so,
Ah, that's
I
great.
was like, I'm making it work. Even if I have to copy and paste my thing into the problem-oriented charting, I'm like, it's worth it because it's just, I can look at the patient more. I can
Yeah.
be more present as opposed to trying to type while I'm talking to them.
Right.
not have to
Right.
stress about it. And it's just so relieving. And to me, this was always my dream, is that, let the technology someday get us back to being better clinicians and being
Mm.
able to listen and pay attention to the patient. So I'm just very jazzed about the future of where this can take us.
That's so exciting. So fast forward a year, what will be your successes or accomplishments? And then fast forward 5 years and what do you expect? Where will you be then?
Yeah. I want this clinic to pay for itself. I think we can generate more revenue than we might otherwise, expand beyond primary care, get that enterprise, additional buy-in, more than just a chronic disease management program, move the needle on all of the outcomes, beyond just even obviously the patient health outcomes are the most important ones, but the RVUs, the patient experience, the clinician experience. And then, as I said earlier, like be a destination clinic. It would be great if, we had enough success that others wanted to learn from it.
That's great. So if you could wave a magic wand with either with this clinic or just generally and solve one challenge in healthcare today, what would it be?
Digital health, we talk about health literacy and how that can have poor outcomes for patients. And it's really a wicked problem to solve. But along those lines, I would say it's digital health literacy. So,
Mm,
our patients that can never get the smartphone to work, or,
mm,
so I can't do telehealth with them, or,
right.
and so I just wish more of my vulnerable patients, didn't have such a difficult time with some of the technology.
Makes sense. It really does. So, what's one early win that will tell you that you're on the right track?
We're starting to set up all the remote physiologic monitoring, and there's some resources that can support that. So I've been doing it on a handful of patients, but if we can get to 75 patients in the next, I'm hoping within the next few months, 6 months, hopefully at the latest, that then I know that we're on the right track. So that's kind of my next big hopeful goal and win.
And milestone. That's fantastic.
Yeah.
So, my final question, and the one that I ask all of my guests, is what's the one thing that we should have talked about today, but we didn't?
I think that teamwork aspect. One, I've got a loving and a wonderful family that gets behind me at home that helps me do and focus on my work, which I appreciate. But then also just the collaboration that I know we have, you and I, Pam, and Howard and others with AMDIS. It's just a great national organization for the connected CMIO. So I'd love for folks to learn about that. But recently we just launched a new Illinois regional user group.
Mm,
So modeled after Wisconsin's EPIC user group, that we've actually had a CMIO group get together over the last 20 years in Chicago. When I was a resident, I went to the first meeting that they had. And it's just been amazing to kind of find like-minded people, find your people, as we like to say. And so building organizations that can do that, whether it's on a national level or a regional level, that I would encourage everyone to kind of find their people, and they're out there, and be a part of it if you can, and give back to those that are coming up behind us.
Well, one thing I've always said, and I think what you're describing demonstrates that, is no one individual or one organization can do it alone. You need collaborators, you need partners, and you need friends. And I appreciate, Karl. I view you as that, and I appreciate your time today. And I think I wish you so much luck with this concept. And hopefully in 5 years, I'll say I saw it when it got started, when you first launched it. I was there and I talked to you about it. So thanks so much, Karl. And
Thank you,
it's been
Pam.
great.